So friends, is just giving a brief overview on thromboelastogram or viscoelastic interpretation of coagulation. So this was asked as a question in DRNB. So it's good. Not many intensivists may be very um, having a good clarity on this take for viscoelastic interpretation. So it's just a brief overview. It's good for all the trainees to have conceptual understanding of this tech. And so wish to acknowledge Dr. Sohini, who helped me develop this content. So I'll just show you a video. So this was from the ICU Reach. So you can just look at how this whole process of tech is done when we are looking at interpreting the coagulation. So this is a machine, as you see. Okay, so as you saw in that video, so a sample of blood is placed in that machine where a torsion pin tends to rotate as the blood starts clotting, and then that the torsion pin is connected to a computer which would create a graph based on the strength of the clot. And as the blood is clotting, the torsion pin starts moving and a graph is created. And then subsequently, as the fibrinolysis sets in, then the intensity of the movement also comes down, and so is the graph. So that's the whole concept of how this machine works and records the interpretation of the nature of the plot. So that is our understanding. So once that is done, so in the text, so this is the sort of a graph that is created. So there are different components in this graph. So for all of us, we need to understand what are the components. So as you see, there is a R time. So R time is the reaction time during which the clot initiation is started. So it's the time taken for the clot to form. And this time is around 5 to 10 minutes. And if R time is prolonged, then it means there is a delay in the clot formation. And the therapeutic intervention when this is prolonged is fresh frozen plasma. So that is our conceptual understanding as to how we interpret this graph. Then there is a K time. So the K time, as you see, starts after the R time. It is the time taken for this clot that is formed to get strengthened. So it's the time for strengthening of the clot that tends to happen. And as you see, the time for that strengthening of the clot, which is K time, is 1 to 3 minutes. And when a graph is interpreted, the machine gives you value of R time with regards to the time, value of the K time with regards to the time. And if K time is prolonged, it means that there is a deficient in fibrinogen, and the therapeutic intervention when K time is prolonged is cryoprecipitate. And then there is this angle, which is called the angle of clot polymerization. And this angle is usually at 53 to 72 degrees. And if this angle gets widened, if it gets increased, it means there is more dilution of the blood. And it is a angle determining the speed of fibrin formation or the fibrin networking that happens is what this angle indicates. If the angle is more, then it means there is deficiency of fibrinogen, which is unable to cause fibrin, which sort of creates the clot. So it's the speed of clot formation, and if this is increased, it means there is deficiency of fibrinogen, and the therapeutic intervention is cryoprecipitate. So then you have, so that is one aspect. So we looked at the R time. If R time is prolonged, you have to give FFP. If K time is prolonged, then it means deficient in fibrinogen, you have to give cryoprecipitate. If the angle is increased, which is the speed of fibrin formation, then the therapeutic intervention is cryoprecipitate for replenishing the fibrinogen. Then the next one that comes is the maximum amplitude. So the maximum amplitude is the time at which the peak strengthening of the clot that has happened, and the time that is considered as a normal is 30 to 70 minutes. So it is the time at which the maximum strengthened clot formation happens, and this maximum amplitude is determined by adequate platelets in the body. So it determines the presence of adequate platelets in the body, and it is also determined by good activity of glycoprotein 2B and 3A and speed of fibrin formation. So the maximum amplitude is determined by all these three components. So the functionality of the platelets, which means the platelets have good. So any drugs that we use, like GP2B 3A inhibitors, they all have an effect on having a detrimental effect on the maximum amplitude, or antiplatelets that you would use, or thrombocytopenia, or even DIC. All these have a bearing on affecting this maximum amplitude. Then you have LY30. So after this maximum amplitude, as you see, the clot slowly starts disintegrating, which we call it as a fibrinolysis. So the LY30 is the lysis that happens after 30 minutes after the maximal amplitude. And the lysis is determined by plasmin and plasminogen. So these are the components. For all our trainees, R is the reaction time, which is the time taken for the clot formation. K time is the time taken for the strengthening of the clot, which is 1 to 3 minutes. Angle of clot polymerization, or the speed of fibrin formation, is the angle. And that angle is related to the maximal amplitude, which is determined by all the components, which is platelet function. So the number of platelets, the functionality of the platelets, and the fibrin formation, after which the lysis of the clot happens, which is determined by lysis at 30 minutes, lysis at 60 minutes, which is determined by plasmin and plasminogen. So that is, in exam, if a question is asked, if you have to put this picture and explain the components, I think that should pretty much tell someone that you have a good understanding. Now we look into the different abnormalities in these. Once when you do a tech, you get various patterns. As you see, this is normal. So because the R time is normal, K time. So when I say normal, you are not expected to see this and interpret it just by looking at it. There are values given. And as I've already mentioned values, there will be I'll show you how the tech done in our ICU comes. There will be normal values and reference values that will be shown. Reference values and the recorded values. This is normal, where R time is normal, K time is normal, maximum amplitude and the angles are normal. And these are all indicated by numbers which comes out in the report. As you see this, very evidently, R time is prolonged. And K time, as you see, this is the K time. You see, it's evidently K time also is prolonged. So both R time and K time is prolonged, and the amplitude also is decreased. So it is very evident. So the possible reason for this is there is some sort of a deficient of factors, so anticoagulants or hemophilia. So there is deficiency of certain clotting factors, and this patient may be on anticoagulants. So, and these are again indicated by the time in the reference values and the indicated values. So this graph, if you see, R time is normal and K time is prolonged. So as you see, the K is prolonged. And as I said, you are not expected to just see this and interpret, because you have to corroborate that with the values that are recorded with the normal values which are given in the report. And as you see, the maximum amplitude and the angle both are decreased. And as I said, whenever your maximum amplitude is decreased, it is dependent on platelet function. It is dependent on glycoprotein 2B and 3A. Then it is dependent on the speed of fibrin. All these three are included. It means even fibrinogen deficiency can cause this problem. So here the problem predominantly is platelet issue. There can be thrombocytopenia, or there can be antiplatelets, or functional quality of the platelets may be affected in this pattern. So those are some of the three patterns you would see. Then this is a very typical pattern. Once you look at it, you know there is a sort of fibrinolysis problem. So there is some sort of a extensive DIC sort of a picture or fibrinolysis that is happening. Fibrinolysis, more of fibrinolysis, because R time is normal. And here this is a typical pattern where there is a continuous reduction in the maximum amplitude. There is a sudden sort of a decay of the maximal amplitude that tends to happen. And the lysis, as you see, there is an ongoing lysis that is happening at 30, which is more than 7.5%, and lysis at 60 minutes is more than 15%. This typically happens after fibrinolytic therapy, like in a stroke patient or in an MI patient. You give fibrinolysis with tissue plasminogen activator or streptokinase urokinase. This is the pattern you would see when you do a take. And this is very typical and characteristic sort of a picture. Maybe here, one look at it, you know, this patient has received fibrinolysis. So this is the pattern possibly we tend to see in ICU, where your R time is decreased. As you see, it's a very short one. K time is decreased and maximal amplitude is sort of increased. And this is due to hypercoagulation. And a similar pattern can happen in DIC. I think this is the pattern we tend to see more often in ICU, where you have this increased sort of a maximal amplitude. When I said when there is a maximal amplitude increase, even the angle can increase, and that determines that the speed of fibrin formation is a problem. And as you see here, there is secondary fibrinolysis, which is like a typically in a DIC. So this is something you could possibly tend to see more often in ICU. So this is one of our patient where we have done a TEG in ICU. As you see, this is how the report is seen. You are not expected to see only the pattern and say, this is fibrinolysis and this is DIC and this is hypercoagulation. See, as you see, it's very clearly evident here. R time is prolonged. See, here you can see, my friends, R time is 16 minutes and the normal value is given. And as you see, K time is prolonged, 11.7, and here the reference is 0.4. And angle, as you see, is less, 18.7. Here it is, and maximum amplitude is less. So here there is a deficiency of all the factors. So which means there is a clotting factor problem, there is a possibly fibrinogen issue, and so on and so forth. So this is the way we would interpret the TEG. So that's about the in brief about the components of the TEG and how we interpret it. Then there is a technical sort of a alternative to TEG, which is the ROTEM. So the reason I wouldn't be talking too much on ROTEM is not many centers in India have ROTEM. Like our hospital, we don't have ROTEM because it's a very expensive machine. But there is few technical differences. Principally, they're all the same. As you see, even in the ROTEM, there is a clotting time, which is called R time. And there is a clot formation time, which is the K time in TEG. And there is a angle of clot polymerization, which we call it as the speed of fibrin formation. And then you have this A10. A10 is 10 minutes after the clot formation. What is the strength of the clot is determined by A10. And we call it as maximum amplitude in TEG. Here it is called maximum clot firmness. It's the same. So in TEG, maximum amplitude is the time at which the clot is at the maximum strength. Here it's called maximum clot firmness. So that certain nomenclatures are different. So this is the maximum clot firmness, and CLI is like there we said lysis at 30 minutes and lysis at 60 minutes. Here it is called clot lysis index at 30 minutes and clot lysis index at 60 minutes. And ML is maximum clot lysis, which we call it as fibrinolysis that has set it. So it is very similar, but here the values are indicated little differently. So I'll only talk about three values that they talk about. They talk about INTEM. So don't get perturbed with this name. TEM is ROTEM. INTEM is ROTEM determining the intrinsic pathway of coagulation, which reflects on APTT. Then they talk about XTEM, which is ROTEM trying to determine the extrinsic pathway, which is related to prothrombin time. Then they talk about FIPTEM, which is ROTEM determining the fibrinogen sort of a function. So, and if these values are heavy, if FIPTEM is sort of less, then it means you have to give cryoprecipitate or fibrinogen. If XTEM is prolonged, then obviously you may have to do FFP, so on and so forth. So it's the nomenclature which is different and technicalities are different, and it is a very expensive machine. I'm told it costs close to 50 to 20 lakhs and not many centers have this. So most in India, most centers tend to use TEG as far as I'm aware. because I just found out that in Bangalore, Narayana has ROTEM and we do not have. So I don't know which other hospitals have. So, but the principle remains the same. In exam, you can put this picture and write this nomenclature, which are a little different. Okay, let's go into, because I think the whole philosophy of tech is some of there is not much of subscription to tech as a tool of assessing coagulopathy by certain group of hematologists, so on and so forth, because tech is little more popular amongst anesthesiologists and surgeons. So let us look into evidence. So this was a sort of a study which came in Annals of Surgery in 2016, goal-directed hemostatic resuscitation of trauma-induced coagulopathy, a pragmatic randomized controlled trial. So here they looked at 111 patients, where 56 were assessed with TEG and 55 were assessed with conventional coagulation assay. And if you see the ability of TEG to very quickly try to attain hemostasis was better because the death was less in the TEG group as opposed to conventional. We all understand conventional coagulation assay, it does take time. The turnaround time is more. And as you see, the death was more in the conventional coagulation assay. And this is reflective of possibly the delay in administration of blood products. And they looked at death within 6 hours, that was less in TEG as opposed to conventional. And of course, this may be a biased study because this is done in the surgical group and trauma-induced coagulopathy. And the need of transfusion, there was no difference between TEG and conventional coagulation assay. But the need of FFP and cryo was significantly less in the TEG group as compared to the conventional coagulation assay. So the conclusions they made in this large sort of a pragmatic RCT was that TEG directed massive transfusion protocol improved the survival and the patients required less of FFP and cryoprecipitate was what was deduced from this particular study. Then this was a huge sort of an observational thing, which came in 2014, effect of TEG and ROTEM and its ability to guide. It was a descriptive sort of a review which came. So here they've looked at 55 studies with 12,489 patients where they have used viscoelastic properties to guide the resuscitation or hemostatic resuscitation. There were 38 prospective cohort studies, 15 retrospective cohort studies, and 2 before and after studies. So ROTEM, there were 2 studies, one in shock and in trauma, and they found that the ROTEM studies were useful for rapid and useful guide to guide the decisions with regards to transfusion therapy and attain hemostasis. And there were studies in non-trauma and trauma, which helped to predict the need for massive transfusion protocols and avoid unnecessary FFP. This was an observational descriptive study where they showed the usefulness of ROTEM and TEG in guiding hemostatic resuscitation. And TEG also helped in early diagnosis of trauma-related DIC and was able to predict the need for transfusion and mortality. So this was a descriptive analysis of a large number of studies encompassing more than 12,000 patients. So that was the study. And there is a lot of evidence in DIC because DIC and postpartum hemorrhage, we know that there is a deficiency of fibrinogen and this needs to be acted on very early. And here they have used TEG and ROTEM and they have come out with guidelines. There are 93 studies in DIC and PPH where hemostatic resuscitation was guided by TEG or ROTEM over 31 years from 1989 to 2020. There were 62 studies related to TEG and 31 studies related to ROTEM, encompassing 32,800. So it's a very large data set where they've used TEG and ROTEM as a tool to guide hemostatic resuscitation. And they come out with these guidelines, like you can follow the FIPTEM, as I said, which is a reflective of the fibrinogen levels. If FIPTEM is less than 4 to 6, then one can act upon giving fibrinogen concentrate or cryoprecipitate. If it is borderline 6 to 8, it could be considered, and more than 14 to be avoided. So these are some of the recommendations that are based on these ROTEM studies. Then the value of ROTEM has gained more importance and significance in liver transplantations, where there is multifactorial hemostatic. So there was a German group which has come with a Gorlinger algorithms where they have looked at maximal clot firmness, which I mentioned, which is akin to maximum amplitude, and they have looked at XTEM, less than 45 millimeter, or FIPTEM less than 80 millimeter. As I said, XTEM is similar to APTT. They've given FFP and fibrinogen. And these are the doses of fibrinogen concentrate they have suggested based on fibrinogen. And if FIPTEM is less than 4 millimeters. So this is basically what I'm trying to say is they've tried to create algorithms based on the values that are derived from the ROTEM with regards to fibrinogen activity, with regards to extrinsic sort of a pathway, extrinsic pathway determination, which is akin to APTT, and determining the need for FFP and cryoprecipitate and fibrinogen. So again, this was another study from UK where they looked at 266 patients, where they looked at maximal clot firmness. And if XTEM is less than 35 millimeter, it was a guide to give prothrombin complex concentrate. And FIPTEM less than 6, it was a guide to give cryoprecipitate or fibrinogen concentrate. And they looked at 58% of the patients. And what they found was with the use of ROTEM, there was no need for giving blood transfusion in 38. There was no need to give FFP in 85%, and there was no need to give platelets in 7%. So all these studies basically reflective on the validation of these tools to guide the hemostatic resuscitation and optimize the usage of blood products was what was shown. So that's about, I think that's in brief overview about TEG and ROTEM. For all our trainees, when this question is asked, it is imperative and expected that you write the diagram and point out to the different components and how these can get affected, and all the different classic patterns that you saw of where R time is prolonged, K time is prolonged, or maximal amplitude is increased, or initially it is increased and then a fibrinolysis sets in, which may be a reflection of early DIC. If you can put those patterns and briefly mention about ROTEM and the ROTEM guided sort of a studies which are validated, that should be good enough. So thank you very much, friends. So you can please request you all to attend our signature conference GIX that's happening on 18th October, and request you all to submit valuable work to Journal of Acute Care, which comes out every 3 months. And you can scan the QR code to visit my website and my YouTube. So thank you, Manipur.